Hi, I'm Dr. James Amos, consulting psychiatrist at University Hospital in Iowa City, Iowa, and this is another Dirty Dozen, this time on interpersonal psychotherapy with user video. I'd encourage you to watch the full presentation on my blog site, The Practical Psychosomaticist at jajsamos.wordpress.com. I'll have a short selection to read from an article by a teacher and colleague of mine, Dr. Scott Stewart, and then I'll go through the slides. There's a dozen of them, and it shouldn't take long. First, in this special issue article by Dr. Scott Stewart, published in Clinical Psychology and Psychotherapy in 2012, entitled Interpersonal Psychotherapy for Postpartum Depression, I'll read some selections about why interpersonal psychotherapy is effective and preferred by postpartum women. It is generally assumed that the efficacy and tolerability of antidepressant medication in postpartum depression is equivalent to that in non-puerperal major depressive disorder, but this assumption has not been empirically validated. Recent reviews of open trials, case series, and case reports of antidepressant medication in women with postpartum depression suggest efficacy, but many of these antidepressant trials excluded women who were breastfeeding, and none were randomized or controlled. A recent systematic review reported that patients with major depressive disorder in primary care prefer psychotherapy over antidepressant medication for treatment if psychotherapy is available. This preference is even stronger among postpartum women. In contrast, there is substantial empirical data supporting the use of IPT for postpartum depression, highlighted by two meta-analyses of psychological treatments for postpartum depression. The first showed that IPT for postpartum depression has a substantial effect size. The second indicated that those psychological interventions for postpartum depression that utilized interpersonal interventions has a greater effect size than those using cognitive interventions. In a study examining the impact of patient choice on outcome, significantly more women with postpartum depression chose IPT than antidepressant medication, particularly when breastfeeding, and outcomes were similar across the IPT alone, antidepressant alone, and combined treatment groups. In sum, women with postpartum depression frequently prefer psychotherapy over treatment with medication. Their concerns about infant exposure to antidepressant medication with breastfeeding, along with a dearth of empirical studies supporting medication for postpartum depression, strongly suggest psychotherapy as a first-line treatment. This, coupled with the data supporting IPT in particular for postpartum depression, make a clear case for IPT as the first-line treatment for postpartum depression. Well, my teacher and colleague Dr. Scott Stewart has done a lot of research and continues to do so in interpersonal psychotherapy. He publishes widely, and he has written the second edition of his groundbreaking text, Interpersonal Psychotherapy, A Clinician's Guide, which will be published by Oxford University Press in October of 2012. His co-author is Michael Robertson, who is director of the Mayo Wesley Centre for Mental Health in Taree, New South Wales, Australia. And of course, Dr. Scott Stewart is professor of psychiatry and psychology at the University of Iowa in Iowa City, Iowa. There's also an announcement that I want to remember to make. There is an Interpersonal Psychotherapy Institute and an International Society for Interpersonal Psychotherapy. The fifth biannual meeting of the ISIPT will be held in Iowa City, Iowa from June 11th to June 15th. You can learn more about the conference, which is held in 2013, on the website for Interpersonal Psychotherapy Institute, which is on my blog site. I'll be following along with the slides here to stay on track. Slide 3 is a definition of interpersonal psychotherapy. It's a time-limited, dynamically informed psychotherapy. The goals are to relieve symptoms and improve interpersonal functioning and social support. It focuses specifically on interpersonal relationships to bring about change. The applications for interpersonal psychotherapy are wide. There have been randomized controlled trials in major depression, dysthymia, and population studied include adolescents, geriatric patients, and those with eating disorders, including bulimia nervosa. It's effective both for postpartum and perinatal depression, and ongoing research is exploring its use in depression associated with cardiac disease, somatization disorder, and patients with AIDS. The essential characteristics are that it focuses specifically on interpersonal relationships at a point of intervention. It's time limited and usually goes between 12 to 16 sessions. The interventions used do not directly address something called a transference relationship, and you can read more about that on my blog site. The premises of IPT include these. Interpersonal distress is closely associated with psychological symptoms. Helping people improve communications in relationships or change their expectations about those relationships relieves symptoms. Helping people build or improve social support networks improves their ability to cope with crises that precipitated distress. When you contrast interpersonal psychotherapy, or IPT, with cognitive behavioral therapy, or CBT, and psychoanalytic approaches, we find that CBT actually focuses treatment on the patient's internally based cognitions. Psychoanalytic psychotherapy tends to focus treatment on understanding the contributions of early life experiences to psychological functioning. IPT, on the other hand, focuses on patients' interpersonal communication with others, and it focuses on helping patients improve their communication and social support in the here and now. The theoretical framework of IPT rests on attachment theory and communication theory, and I'd encourage you to go to my blog site to read more about that. The problem areas of focus for IPT include grief, interpersonal disputes, and role transitions. And they can be losses in terms of grief, such as death or divorce. Interpersonal disputes cover a wide array of conflicts with others, and role transitions include life cycle changes and social transitions as well. The therapeutic process and techniques actually focus on how to help people use what they learn in interpersonal psychotherapy in their real lives, rather than on techniques per se. Conducting IPT goes through several phases. There's an opening, middle, conclusion, and maintenance phase. The opening phase usually has three main goals, which is to diagnose, frame the treatment to follow, and to relieve symptoms. And that usually takes about 2 or 3 sessions. The middle phase is taken up with the meat of helping people understand what's going on with their communication styles, and helping them identify the feelings associated with interpersonal issues, validating the feelings, and helping the patient explore options for change. In conducting IPT, use is made of communication analysis and interpersonal incidents, in which we ask the patient to describe the interpersonal incident in detail, recreating the dialogue as accurately as possible. And of course, the last slide is references and resources as usual. There is a quiz. I hope you've enjoyed the presentation, and I hope you'll go to my blog site and make use of the free resources there to explore it in greater detail. Thanks for listening, and I'm looking forward to your questions and comments.